Where do you want? Are we just the two of us, or a bit more people?
To the clinical session are kindly invited to have a seat over there for questions, or maybe be on the front. Well, we have a microphone.
Esther?
That would help.
Do you want to
switch on the microphone?
The basket?
Switch on. No, it doesn't work.
Switch on. Faut appuyer sur le petit.
Okay, so the design of a basket trial could be a good idea. So just a couple of comments. So far we have no validated methods for addressing hypoxia. So I mean, you consider FMIs or other tracers. So far, to my knowledge, only a paper on head and neck recently published on the Green Journal have tested and validated, internally validated, a signature, hypoxia signature for head and neck cancer, and currently this signature is under validation worldwide. Okay, so the first point is we don't have a validated methods for defining hypoxia. This is the first one. The second one is that also in my pilot study I will select patients HPV negative oropharyngeal cancer patient. At the beginning I consider also locally unresectable, locally advanced non-small cell lung cancer, but since the recent data of perioperative of neoadjuvant immunotherapy in lung cancer, so maybe I decided to consider only HPV negative patients. But in this case, so at now we have no gantry, and we need to treat the elective volume, the elective volume at the beginning, and the boost volume. We need to give a mixed beam approach. So this is so only for. I consider for my trial also patients with specific peculiar retroperitoneal sarcoma, so histologies for which we can consider preoperative radiotherapy. And for this we can choose between a full course of carbonion and full course of protons, but for other cancer types we have to consider that carbonion should be we have to combine carbonion with photons or protons. So the first one is the lack of validated methods for studying hypoxia, for assessing hypoxia, and the second one is the extension. I agree with the idea to consider tumors according to biological properties. I agree. So if we consider that brain tumors are classified now according to molecular profile, we have no reference to specific histology. So I agree with the consideration, with the assumption to consider according to the biological properties, but we have to decide what is the biological property, and hypoxia can have some limitations so far.
Yeah, that's why we need that 2025-27 period to do some imaging and correlate with other markers before this trial can be set up. That was the point. Yeah.
But why not do anything? You can do anything with carbon, and maybe you can, because to implement another biological marker with a special dedicated PET scan, which is only available at one place in France or in Italy. It complexifies a lot. It's already very difficult to do a trial. Only the trial from Jacques was really difficult only to send patients. It was feasible, but quite difficult. So I think to add some biological is maybe we could do it as an ancillary study. And if we did it, it's nice, but it's not, I think, mandatory for all patients to have it. And as the data show, we can do a full treatment with carbon, and maybe to do a full treatment with carbon, it's easier. But
I think there are 2 points. The imaging that we have here, and actually we are very lucky because we have CIRT where we have all the modalities that I mentioned. I don't know if Samuel or Miriam want to react, or so that no. What do you think about the validity of the imaging of hypoxia?
Thank you, Juliette, for this quite difficult question. Yes, hypoxia imaging is still challenging. Here at Caen, we have the chance to have access to a cyclotron and to produce F-MISO. So you just mentioned that maybe it can be a bit challenging, but maybe not so accurate, but we have no more than that. In different tumor locations, we already showed that it performs well. I mean, in glioblastoma, for instance, we have good correlation between F-MISO and molecular tracers. We have also the chance to have access to advanced MRI, so we launch different trials with bold effect, for instance, oxygen-enhanced MRI, and we are trying to correlate this kind of imaging. So yes, it is still an open question. I would argue that F-MISO remains one of the gold standard. One of the main disadvantage is the cost, because accessing PET tracers is quite expensive right now. So I think we have to work on it. But yes, we just can comment that we have the chance to have access to these devices, and we need to work further on it.
Unfortunately, in Italy, we have no F-MISO currently, so and other PET tracers for hypoxia.
I think Juliette mentioned that we should further work on the comparison between maybe circulating markers and F-MISO, for instance. If we have access to F-MISO, it is good. We also can buy other kind of tracer, such as FASA, for instance, which is well known in lung cancer, for instance. So yes, we still need to think about it and to work with these tracers, but hopefully we have it in Caen, and we also have access to MRI, so we need to work further.
So thank you for bringing this. I think that the hypoxia is a very important topic, and just give you my personal view. There are 15 carbon ion centers in the world. There are many more cyclotrons that are able to produce radio drugs to trace hypoxia. I think if you are thinking of carbon ion, we should really make an effort and say, this is an interesting research, and then the hypoxia imaging must be made available and we must find funding. I think it's a little bit like putting ourselves limits that are not true, saying, no, we cannot do that, and it's extremely important to do that. Now, of course, there is no validated or agreed upon. I think, honestly, that F-MISO or cooperate, I mean, we have the German data from Tübingen and Dresden showing that F-MISO is very, very strongly predictive of outcome with HPV negative oropharyngeal cancer. We have data showing that cooperate TSM is predictive of survival for cervical cancer. We have accumulating data of circulating biomarker of hypoxia. This trial could also be a way to test an expensive and difficult modality like the best PET you have and use it to validate a most more easily accessible modalities like Voldemar or even better circulating. So that could be part of the package. My personal point of view would be the basket trial is another layer of complexity, and maybe you could start with something single, select one indication and do only one indication. And I loved your focus on reoxygenation. I would put even more focus. I think we don't need to find a signature of an hypoxic patient at start. Who cares at hypoxia at start? We really have to focus on reoxygenation. So there we might discuss what is the role of carbon to solve the poor response of the non-reoxygenator or induce the reoxygenation in everyone. That I think would be a very interesting question. So far it's always carbon ion is good for hypoxic tumor and kills the hypoxic tumor. We are not putting enough effort in showing carbon ion is actually very, very good in inducing better and faster reoxygenation.
Thank you.
Maybe as one of the oldest one in this audience, I could remind you that there is a very big body of evidences that we could exploit, which is the experience that was accumulated using neutron therapy. Just high-energy particles like carbon ions minus the Bragg peak, of course. And so I remind you that what was selected at the time for neutron therapy were tumors which were hypoxic, just like you mentioned, which were slow-growing, that had slow alpha and beta value and low radiosensitivity. And for example, one of the paradigm for this usage was the salivary glands, which were considered perfect indication. And you mentioned this morning, by the way, for carbon ions as well, the parotid glands or salivary glands. So, of course, we could definitely exploit also this very large body of experience we had before. I remember also that prostate was considered at the time of neutron therapy as one of the best candidates. So this joins what we know now using carbon with this extensive experience in Japan. And I also took a very important message this morning from our Japanese colleague. I'll tell this for our young staff which are here, which is the variation of the RBE depending on the dose per fraction. And it was clear from one of the slides I could pick up was that when we increase the dose per fraction, you are decreasing the LET and RBE, which as far as local control is not too good, by the way, but the slope for normal tissues and for tumor is different, is much steeper as far as normal tissues, and so you have really a great interest by increasing the dose per fraction in order to keep some good efficacy on the tumors compared with the normal tissues that improve their tolerance. So I think this is basically the rationale for our Japanese colleagues. If I'm right, Dr. Ono? Mm-hmm. Okay.
Yes, I think also to focus on one histology, to be simple and to answer a question relatively quickly. For example, now in proton therapy, the MD Anderson phase 3 trial, which apparently is positive for toxicity, but also for overall survival. It's not yet published, but if it is the case in France, the health insurance, we will say, okay, we have to open 3 or 5 more proton centers.
Yeah. But you're referring to Stephen Frank's trial, but it was like 440 patients from 30 centers in the US. And the problem here, by just using one histology, that we need to refer to just one center. And that's going to be, I think, the main issue. That's why the basket trial was like maybe an option.
Maybe we could do international trial.
Yeah, we have to make it international for sure, but still.
Jérôme, you might remember the joke that we had in a common meeting with your group in Nice. You were supposed to treat 300 patients per year, and we also had capacities for doing general anesthesia. So we recommended to have all the kids under general anesthesia in your place. You are not so happy.
Yes, but I think it's feasible. The EPTN, the group from SFRO, succeeded to collect 3 million euros from the H2020 fund, and with IBA also, the support of IBA to conduct a phase 3 trial in esophageal cancer. So I think maybe it's also, and this group is also maybe interesting in carbon. I think for sure, yes, Heidelberg is in this group and many other groups. So I think through European, through SFRO, it's feasible to conduct phase 2 randomized 3, phase 2 randomized to check if there is a signal, and if yes, we move on to the phase 3, and then we maybe not a rare indication at all, like head and neck, but the list you proposed was nice, I think. But yeah, lung cancer is still a great challenge.
Yes, because we need the imaging in room that is more difficult even than for head and neck.
In rectal cancer, we have the fashion to conserve the organ and to remove surgery. And also pancreatic cancer is one of the greatest challenge, and maybe pancreas is a great proposal for future phase 2, 3 randomized trial. We need randomized trial to convince health insurance. Otherwise, particle therapy will not move forward.
Yeah, that's a big constraint we have, and we really need to find a way to improve the level of evidence. Yeah.
Is Arnold in the audience? Arnold, I would be pleased if you could present orally some data as far as the project, the international project conducted by US as far as pancreatic cancer. I believe this could be of great interest.
Now.
Oh, now.
Project.
Okay, now? Because that was half of my talk tomorrow.
It's part of your talk tomorrow?
Yeah, but I can briefly mention it, right?
Maybe briefly mention.
Yeah, briefly I can mention. So we put together the first randomized phase 3 clinical trial comparing photons and carbon ion for locally advanced unresectable pancreatic cancer. So now you guys comprehend all what I said. This was pretty long. And then we opened and activated this clinical trial in QST, in CNAO, in IEO, at UT Southwestern, in Gunma. So these were the 5 initial sites that were activated. That means done. That means all the standardization of dose distributions, of output measurements of the machines, of all the QAs have been done and performed, and it was activated.
So sort of demi-run, you mean?
Yeah. So that was done, and we activated it on, guess when? February 20, 2020. And then March 15 of 2020, the world shut down. So because of COVID. So then, since then, we're still licking our wounds, and we have not been able to redo this. And what was this? This was the IMRT photons versus carbon ion, both with chemotherapy, and randomized. So I can talk more tomorrow without details, but if you guys have questions. So this could be done. That was the message. The idea was, if, for example, American patients get a randomized to carbon ion, the patient would be shipped to Japan, and QST would be treating. If an Italian patient gets randomized, obviously it would go to CNAO or would go to IEO. Photons, Americans would be treating. So it was all thought through and activated.
I was about to ask Dr. Neusier if she would agree to conduct such a trial for the French side.
Yeah, I think that locally advanced is the right indication for this kind of clinical trial.
Because you are the first gastroenterologist, the first to choose the patients.
And this room actually has the absolute top experts who enabled this, right? So Piero from CNAO, right? Plus, like Sandro from CNAO. Plus, we had IEO was Dr. Orecchia. Plus, then Dr. Yamada from QST at that time, right? Dr. Kamada from QST. And from Gunma, Dr. Ono is here. So this is it, guys. If you want to regenerate it, this is the moment. Everybody is here. All we need is to cough up the funding for it.
What about the young lady in your group? Dr. Nézinier, do you agree? Okay.
Right.
We have to move on. I was a bit disappointed. Nobody talked of the abscopal effects because there are data about abscopal effects. Marco Durante, who unfortunately could not be with us today, has made some presentations and papers about this, which is quite an exciting topic. Even, well, our radiobiologists here in Caen also have some interest in this. Well, would you like to make a comment?
I will present.
You will present. Okay. Right. Great.
Okay.
Piero, something?
Another topic. First of all, please are not mention Dr. Yamada, and then all the rest of us came significantly after. So if you want to make the list of experts, don't mention me as first. After that, there was another issue which was quite interesting in the CIRT trial, and you were mentioning lack of support from the vendors. Well, if you do a similar trial and test an innovative drug, very expensive drug, you get a very expensive drug for free. And they said, oh, then you have to treat carbon for free. But there is a structural big difference. If you give the expensive drug for free, it's not really leading to any loss of revenue, because Pfizer or AstraZeneca will just produce 2 files instead of 1 and give you 1. It's not that they give you the one that they would sell to the real patient. But for us, if we treat a patient in the CIRT trial, the same slot we don't use for a patient that would have been a big revenue. So when we think of this carbon ion trial in terms of really research and innovation, we have the issue of loss of revenue that you don't have in pharmacological trial, and it's a big issue and cannot be put under the rug. In QSD, they had significant funding from the government. Not every European facility have that. So who is paying for the patient treated in the trial? Not the cost of the randomization, data analysis, data manager, going to the conference presenting, but the cost of the treatment. And the normal grant structure of the European Commission, if you ask them, give me the cost of the treatment for an experimental treatment, they say, are you crazy or what? Well, no, this is our reality.
Yes. Actually, we have what mentioned Professor Balboso this morning, the PHRC, which are the funding of the clinical trials, and in theory, I say, they should pay as well for the excess of cost of particle therapy compared with photon therapy.
Yes, they pay for the excess of cost if you say this is the established treatment for salivary gland. But if you want to do something really crazy, anticipated boost in non-small cell lung cancer to induce reoxygenation, no one is doing that. That's real research. So will they also pay for real research, not just for producing the evidence that what is already standard of care is better? They are not the same topics. So I'm not so sure you will convince them to fund combining grid carbon with immunotherapy to induce immune response in pancreas, even if it's microsatellite instable. This I would love to do, but they will not pay for that. You need someone that funds that.
I totally agree with you. That's why, for example, this morning I recommended to have a very precise topic like pancreatic cancer, not radioresistant cancer in the abdomen, which would be different as far as the reimbursement by the national health system. It doesn't mean that we should not do it. Of course, it's an important topic as far as radiobiology, but sponsoring by the Ministry of Health is crucial.
And for the abscopal question, Jean-Louis,
yeah.
Yes, I think we'll tell tomorrow that particle therapy, proton and carbon have a great future because they spare a lot the mean dose to the body, and lymphopenia is strictly correlated to this mean dose. So I think in the tumor location where lymphopenia is strongly correlated with overall survival, it has a potential. So lung cancer a lot. So the phase 3 trial with carbon versus proton or photon are, I think, of interest. Maybe the latest data, Pacific 1 versus Pacific 2. So the Pacific 1 established durvalumab as the standard of care after chemoradiotherapy in locally advanced non-small cell lung cancer. Pacific 2 tested to use durvalumab during chemoradiotherapy, and it lost the effect. So showing that you have to finish radiotherapy when you begin immunotherapy, because you kill the activated lymphocytes. So the design we saw this morning from Japan, maybe in France we designed a trial in breast cancer in triple negative, and we completely transformed the design to first begin with radiotherapy and then do the chemoimmunotherapy, because after in Astro the LU005 trial shows the same in small cell lung cancer, and last week in esophageal cancer the same story, and also in head and neck. So I think yes, particle therapies as a future, but before immunotherapy I would say a comment.
I'd just like to take a perspective. Over in Mayo Clinic, we're facing similar challenges as you are in Caen, in that we won't have carbon ion for another 3 years, and so we're trying to figure out the appropriate studies to do in the time while we wait for it. And we've identified similar areas of interest. So really identifying the patient selection, and we like to try to bring carbon ion therapy to larger patient populations, and so those with non-small cell lung cancer who are at higher risk of local control, if we can identify those patients up front, obviously we think that these would be the great place for actually bringing in carbon ion therapy. So we're putting a lot of our resources into looking at a multi-omic analysis of the tumors to see if we can identify increased risk of local recurrence. We're looking at FFASA to see if that might be able to help us understand which patients are going to be at higher risk. And then with that data that we get with our photon therapy in the next 3 years, we can then compare that with our carbon patients once we have carbon ion therapy. I think it's a similar approach, and I think really trying to expand this use of carbon ion therapy to these more common cancers is what's really going to have a big impact in the field.
Thank you. Okay.
Just a short comment, what you said already. It's not only a matter of lymphopenia, it's a matter of immune cell composition at the beginning and during the treatment. And the disappointment of the Pacific 2 trials is not why we give it why we kill too many tumor cells. It was in the 90s, it was proven that radiotherapy, also with big fields in the mid-90s, we had much more volume we treated, that we lose immune cells. That's a fact, but we don't lose the immune system. Yeah, many of the cells stay here and they stay reactive. We and others showed this in several instances. Yeah, but you should have to say that when you kill a tumor cell, yeah, they also try to enhance immunosuppressive molecules on the surface like PD-1 or something else. And then we need the therapeutic window is very small to get the antibody in, and then the immune suppression will be released. So all immune therapy should be as near as to the end of the radiotherapy, at least at the end phase of the radiotherapy. And the way they showed this, I think it was 2008 or 2012, that at the beginning it's not so efficient than at the end of the immunotherapy. Yeah? So, but it's not only of lymphopenia, it's a matter of immune cell composition. And especially the innate immune cells, mostly overlooked, yeah, play an important role today in tumor immune suppression.
Could we argue that flash particle therapy is the best? Because as far as sparing immunological system, it's perfect, you know?
Well, we know that we need data.
Juliette, I would underline that I agree with the behavior to set up a trial considering patients according to a biological signature. So we have to think simple. So at the beginning, we can consider hypoxic patients according to, we can decide what is the signature. So this is at the beginning. After this, we can consider, so the idea by Piero is an excellent idea, but I think that we have to think we have to work step by step. So if we consider an hypoxia signature for selecting patients, we could consider patients already included in national indication. So for example, I think that we can include half of patients with a standard indication. So for example, sarcoma, we know that among sarcoma, according to the Torres-Roca signature, we can distinguish between high radioresistant tumors and relatively radiosensitive tumors. So we can apply also this signature for current indications. This is a method for personalized. Okay, so I would consider half of patients with standard indication and another one with a new indication according to the signature. So this we can spare an amount. So I agree with Piero. This trial don't allow the reimbursements for treatment, but in this case we can consider a lot of patients with usual indication.
Are we closing the round table or any other comment? Ole?
So that's a junior question. So please forgive me if it's not relevant. My question was about the recruitment in basket trial. I said in presentation before, the major part of the patients in Proton and Carbon Center come from outside the region. In France, in France, when there is demand for Proton Center, usually the demands came a bit late compared to what we should expect. How can we convince center from outside to send us patients for basket trial using carbon, and how to place the role of carbon versus other option that can be available in closer centers such as SBRT.
Yes, to address patients, for example, in my center in Nice, it takes, I think, 10 years to have a continuous addressing of patients. But as soon as your colleague...
Years, you said? Waiting list in your place?
No, I know it lasts 5 to 10 years to have now now our center is treating. We have no room anymore.
I feel better.
And but yeah, to have and to make the colleague happy from other cities in Lyon, Marseille, Montpellier, Toulouse. Yeah, of course you have to be quick, efficient. You have to answer by SMS and not only with Proton share, which is nice. But in addition, we have to be efficient. And then they have the reflex, and they think about EV ions. And if we say, be aware, there is a trial in Caen, if you have this kind of, I think I'm optimistic. It will to address and to answer phase 2 randomized trial, and we could think about SBRT versus Proton versus carbon versus no treatment.
Just a comment and to participate in the answer. I think that if you choose some
tumor where we don't have any good option. And I mean more than pancreatic cancer, for instance, recurrent rectal cancer. Because these pelvic recurrences are often, during a long time, the only recurrence without metastatic risk or with a low risk of metastasis. Regarding locally advanced pancreatic cancer, you could have, of course it's interesting, but you could have an objection of the physician or of the patient. You know, if the lifetime is limited, and you know the median overall survival for such patients is about 12 to 15 months. Do the patients want to go during, I don't know, 1 month outside, far from their home, far from their families?
It depends on the conviction of the physician, of the patient. If you and
both, and that's another problem, is that there are some social inequalities, because some high social patients will go where they can go, and even in other lands, other countries, sorry, but not low-income patients.
Yes, actually, the French government, for the last 4 years, it reimbursed now the cost of transport and housing, and the patient only have to pay 15 € per day for the meal. So, 70% of our patients come from other cities. Thanks to this system, but of course, we cannot include all patients with low income.
So, may I just follow up from the question? Because actually I have a very pragmatic question. As Juliet said, trials requires funding. And Arnold, when he talked about the trials that we put together, there was a call from the government in the US. Okay, so if we are talking about trials, where is the funding going to come from? And we used to talk, as you just said, talking about again, patients going within France, yes, there's a system. But if you want to do an international trial and you want to send patients to Japan or to Germany or to back here, I mean, the resources, the funding, the logistics are quite complicated. So it's a stupid question, but somehow we have to be able to fund such an international trial.
The model that we have in Europe is more like some of the country. One of the countries proposes a trial, and then, like, let's say Denmark, and then if France wants to participate, they have to find their own funding. And we are lucky enough to be able to do that with the French National Cancer Institute, where we have some calls for trials, and we can apply to integrate a trial that was designed in another country. So that's possible. Or it could be at the European level, with different countries participating.
Sorry, no, I agree. Which is really good that France does that, but we are talking about carbon ion. There aren't that many facilities, of course, and we're looking at specific trials. So that's why I'm wondering is that we have to figure out a way of also patients from the other country can come across as well. Yeah. And it's not so obvious and easy. So Arnold is going to tell us tomorrow, but I know that was triggered by the fact that there was a call in the US for carbon at that point, a comparison with protons and conventional. But he will tell us more about it. But we need to think about how to make that happen and feasible if we want to do this.
And sorry for repeating the same thing twice, but it's very close to my heart. That NCI call was covering patient travel cost. That analysis was not covering the treatment. No one is covering the treatment. And there is zero contribution from the vendor. If we have one positive phase 3 trial with survival advantage and the publication on the New England Journal of Medicine, then Hitachi and IBA and Accel, they will sell more equipment. One machine is 200 million. One trial is 1 million. The day that the interim analysis of the Pacific 1 trial was published, the stock options of the pharma company producing durvalumab went up 30%, and this opened the market of billions. So this is indeed something that we should discuss again with the vendors. This is a good investment for them to support these trials.
Absolutely agree. Yeah. And spy on the New England Journal of Medicine for the head and neck trial. It should come soon. Okay, let's close the session. Thank you, everybody.
Thank you.